Hi, my name is Gabby. I'm a recently graduated Hertz Fellow. I did my PhD at Stanford working on mucins in cancer, and I'm currently at the Gates Foundation as an Associate Program Officer at the Maternal Newborn Child Nutrition and Health team. And I'm really excited to introduce both the speakers today as well as give a big overview about how today will run. So today, Emma and Francesmary will each share a short impact spotlight highlighting how large-scale data, computational approaches, and collaborative research can advance women's health, cancer research, precision medicine, and broader public health. And then after that, our other, moderator, Freja Ekman, who is a current MD PhD student at Stanford and a current Hertz Fellow, will facilitate this live 20 to 25-minute audience Q&A. And that will answer your questions with the speakers. And for that, we'll be using this app called Slido, which I believe will be dropped the link into the chat right now. And we really invite you to submit questions for the Q&A using the link and then upvote questions that you really like so we can make sure we get to that. And I believe the QR code, the bottom right, also links to that Slido. And I think that that's going to be on some of the slides as well if you lose access to this chat. Cool. So with that, I would like to introduce the first speaker, Emma Pierson. Emma is a Zhang Family Endowed Professor and Assistant Professor of Computer Science at the University of California, Berkeley. Her lab develops machine learning methods for health and social sciences in order to build a fairer, healthier world. And she has a particular interest in using LLMs and sparse autoencoders for scientific discovery and building fair algorithms in healthcare. She has quite a few awards, including was a 2014 Hertz Fellow when she did her PhD, and also to name a few others, NFS Career Award, Rhodes Scholarship, and an MIT Technology Review 35 Innovators Under 35. Her talk today will discuss how computational and machine learning approaches generate new hypotheses, support evidence-based decision-making, and identify patterns that improve equitable healthcare across cancer and public health. And so with that, I'm really excited to hear the talk, and I would like to turn it over to Emma for her spotlight.
Thanks so much. Wonderful. Thanks very much for the opportunity to speak today. It's an honor and looking forward to the subsequent discussions. So as mentioned, my research broadly develops machine learning methods to reduce inequality and improve healthcare. And today I'm just going to give you a sense of some of the high-level themes and project directions that have pervaded our work. And of course, I'm very happy to dive into some of the details if they're of interest. So one direction we have worked a lot on is trying to make fairer decisions. For example, we've done a lot of work on trying to improve the fairness of human decision-making. One thing we've thought about extensively is a major public health concern, policing, and sort of inequality in policing. And so we've extensively studied police decision-making. For example, we compiled and released large-scale data on police traffic stops across the country, developed new statistical methods to analyze this data for racial bias, and found evidence of bias in both the decision to stop a driver and to search them. And this work has influenced policy in major American cities. We've thought a lot about fairness of medical decision-making as well, including identifying flaws or deficiencies in sort of clinical decisions. We've also done a lot of work to improve the fairness of algorithmic decision-making, since algorithms increasingly influence decisions in high-stakes domains, including medicine, but also in criminal justice and so forth. One question we've thought a lot about recently in the clinical context is when algorithms should use a person's race to predict their health outcomes or to inform their medical decisions. So to be concrete, if, for example, you're a Black patient versus a white patient, should you be getting different decisions or recommendations or predictions if your health measurements are otherwise the same? So one question we considered, for example, is whether a person's race should be used in predicting their risk of colorectal cancer. The reason we care about this question is that it's actively being debated in many medical domains, and it's immediately influencing patient care as hospitals and health systems actually revise how they make these decisions. A second broad direction we worked on is scientific discovery to improve health and reduce inequality. And we do this out of sort of the core belief that AI really can supercharge our ability to extract signal from vast new medical data sets. And if we choose to focus this ability on populations we've previously been blind to, that's a powerful force in service of a more equal world and more equitable healthcare. So one example of this would be our work trying to understand inequality in knee osteoarthritis pain. There's a lot of racial and socioeconomic inequality in knee osteoarthritis pain where patients from disadvantaged groups experience greater pain. And even more interestingly, this inequality persists even when you control for how severe the doctor thinks the disease is, based on looking at an X-ray. And we asked the question, can an AI model identify features that are relevant to pain and that help explain inequality in pain that are being missed by the doctor? And we find that our model does find additional signal within the knee for predicting pain, and that when you control for this signal, you can narrow the unexplained pain gap and better explain inequality in pain. This finding matters because it suggests that traditional clinical severity measures fail to capture all the physical knee features that could help explain why disadvantaged groups experience more pain, and that AI models can potentially help us better understand inequality. Another example is our work on mobile health data to understand cycles in women's health. So here, you've got millions of women all over the world who are logging information about their mood and their behavior and their vital signs in sort of women's health apps. And so we took this very rich data and we used it to provide the first decomposition of women's mood, behavior, and vital signs into 4 simultaneous cycles: menstrual, daily, weekly, and seasonal, thereby improving understanding of the menstrual cycle and of women's health more broadly. We've also worked with mobility data from cell phones, tracking where people go from minute to minute or even second to second. And we've used this sort of mobility data in a lot of applications. We've used it to measure inequality in human movement patterns and to develop a model of how COVID spread across fine-grained human mobility networks. Intuitively, if you sort of know where everyone is going, right, you know who they're mixing with. And this is really important to model the spread of infectious disease. So we developed a model of how COVID spreads and use this to improve our understanding of how inequality in mobility gives rise to inequality in infections, and also to inform fairer and more efficient ways to reopen after the COVID pandemic. We did this work in sort of the early days of the COVID pandemic, and this model informed policy both nationally and internationally. In more recent work, we used mobility data to more accurately measure socioeconomic segregation. So that's sort of loosely, how much do the rich and the poor actually come into contact with each other? How much do they mix? This matters, it has sort of, it's been correlated with negative public health outcomes, with, downstream economic inequality, stuff like this. And so it's something we care about, but it's something that's quite hard to measure. Intuitively, if you have cell phone data, you can more accurately measure how much the rich and poor mix. And so we use this to develop more accurate measures and understanding of socioeconomic segregation. In more recent work, we've also worked with longer-term mobility data. So here we're tracking movement not just over minutes or over months, but over decades. In other words, people's migration patterns over the course of their lives. And we use this data to recently release data on migration patterns in the United States that's thousands of times more granular than data that has been previously available to researchers. This matters because a lot of the migration stuff you would like to measure, like how do people flee a flood or a wildfire, you really couldn't measure with the data before because it was just too coarse. It was only at the county level, and more than half of moves in the United States are just within county, are entirely invisible in this data. So we released this much more granular data that's already been used by researchers all over the world, as well as folks at the UN and in journalism and in various other governmental organizations. And we showed this data can reveal important migration patterns that are invisible in previous data sets. For example, we showed that it can show you how people are migrating away from California wildfires. I live in Berkeley, so this is a topic of great interest to me, in ways that were really invisible in previous course data sets. And we're very excited to see what other researchers will do in this data in the social, environmental, and health sciences. And finally, like everyone else, we've gotten very excited about large language models and how these can be used to accelerate scientific discovery from text. We recently created a new method called hypotheses that helps you generate scientific hypotheses from large text data sets, like what features of a patient's clinical notes predict if they will develop cancer, or what features of a headline might predict whether it will go viral, or things like this. For example, as shown on this slide, our method automatically discovers that headlines about the environment or headlines that address collective human responsibility get fewer clicks, which is interesting, although a bit depressing. And so we're quite excited to apply this method to other text data sets to try and discover interpretable text features that predict important downstream outcomes, both in the context of health and in more broadly. We're also interested in taking these same methods and extending them to things beyond text. And one interesting thing we've seen is that, an analog of the method we developed for text is also generating exciting and promising results for other data modalities. So what I'm showing you on this slide is a picture of a bunch of eyeballs, loosely, retinal fundus images is the more technical term, but eyeballs, is fine too. And what we've shown is that our method can sort of automatically identify clinically important significant and very interpretable features in these medical images, which historically has been a very difficult task to do. So here, the images at the bottom differ from the images at the top because they all show multiple dark red interretinal hemorrhage spots, which is an important feature in diabetic retinopathy and was automatically identified by our method without being told that sort of the task was to predict diabetic retinopathy. As another example of this, we've also been applying the method more recently to ECGs and shown that it can identify interpretable ECG features that predict downstream outcomes. So here, folks, who are manifesting the ECG patterns shown by the blue line have higher mortality rates than people who look more similar to the orange line. We don't understand why that is, but it's certainly interesting that we're picking up on a clinical pattern that seems to have some downstream prognostic value. Even more interestingly, the sort of predictive strength of that pattern persists even when we sort of try to kill the signal by throwing in a battery of standard clinical controls. So that's an example of how we're trying to use these methods for scientific discovery. And then finally, just to close, throughout this, we've really tried to focus on practical impacts. We're agnostic as to what statistical methods we use. We're using a blend of sort of classical and modern methods, old school stuff, new school stuff, whatever works is fine. We do this work in collaboration with interdisciplinary people from both the social sciences and the medical sciences, as well as sort of other computational domains. And we really try and make it so that our findings don't just sort of get buried in the ivory tower, but rather accessible to policymakers and the public by writing not just for academic publications, but also for mass audience publications. So if that sort of scientific communication stuff is of interest to you, very happy to discuss more. That's an overview of what our lab does at a high level. All of this work it would not be possible without a wonderful group of students to whom I'm very grateful and lucky to work with.
Thank you, Emma. That was wonderful. And I'm really excited to hear the questions that people want to ask. And that's just a reminder. I think we've had quite a few people join since I first made that statement, but in the chat, there's a link to the Slido. So if you have questions about Emma's great presentation, please type them and then please upload on the questions you want asked during our Q&A after. And so with that, I would also like to introduce the second speaker, Francesmary Modugno. Francesmary is a professor at the University of Pittsburgh in the Department of Obstetrics, Gynecology, and Reproductive Sciences. She was the first PhD graduate of Carnegie Mellon University Human-Computer Interaction Institute and also as a Hertz Fellow. After completing her PhD, she joined the Computer Science Department at the University of Washington. But then after that, her mom was diagnosed with breast cancer, and that really pivoted her. And she went back to school for Masters of Public Health from the University of Pittsburgh with a focus on cancer epidemiology and prevention. And so now Francesmary is a molecular epidemiologist focused on women's cancers, especially ovarian cancer, breast cancer, and endometrial cancers. Looking through her impressive bio, something that I found really interesting was that she led the HOPE study, which is the largest ovarian cancer studies ever undertaken in the United States. And so that's a really important thing when we start to think about uncovering huge signatures and data with large data sets. And our talk today is going to discuss the unmet needs in women's cancers, showing how population studies and collaborative consortia can identify the social, structural, and biological factors that influence outcomes and inform interventions. And so with that, I'm sure we're all really excited to hear the talk by Francesmary. So I'll turn over to her to present her slides and give the talk.
Okay, can you hear me? Okay. I wanted to drop my slides into the chat so people can just have access to them, but it says administratively I can't do that. So I'm just going to ask that you allow that. Then I will then drop my slides in so people can have a copy.
We can do that for you, Francesmary. Go ahead and we'll get them sent out.
Okay. All right. Thanks. Okay, so thank you all for coming today, and I'm really honored to be talking to you. I'm going to jump right in. This is going to be a very high level and quick talk, so hopefully it'll be a springboard for dialogue and future work. So I focus on women's cancer. Cancer in women is a growing.
Francesmary, sorry to interrupt you. We've got a little thing in the middle that says continue to share.
Okay,
Yeah,
how's
thank
that?
you. Do you mind going back to so we get a shot of the first slide?
There you
Thank
go. Okay. All right. So this year we're going to see over 1 million women will get a cancer diagnosis and almost 300,000 women will die from their disease. These numbers are only growing. The rate of new cancers for women in general are increasing, as are the rates for women's cancers, specifically breast and uterine cancer and several other cancers. Now, the good news is that cancer deaths are going down, with a few exceptions, most notably uterine or endometrial cancer. However, we see persistent disparities, especially in outcome. Here we see that for all cancers, but particular to my work, Black women with breast, uterine, cervical, and not shown here, but also ovarian, have significantly worse 5-year survival compared to white women. So this brings us to the question as why do we need big data and consortia? And I'm going to refer to this as our complexity challenge. And our case study is going to be ovarian cancer. The ovaries, normal ovaries are about the size of almonds, but when most women, about 75% of women, are diagnosed with ovarian cancer, it is this big, bulky disease that has overtaken the entire peritoneal cavity. And just for your benefit, you could see the surgeon's hand in the upper right corner. That's how large this disease is at diagnosis. Now, the good news is that ovarian cancer is very rare. We're only going to see about 21,000 cases this year. It's not even in the top 10 of cancers for women. Unfortunately, it's highly fatal. It's the 6th leading cause of cancer death in women. It's the most fatal gynecologic malignancy. And compared to all malignancies, it has the 4th highest mortality to incidence ratio, only behind pancreatic, liver, and brain cancers. Now we know that there are a number of ovarian cancer subtypes. They have different histological appearances. That's what you see over on the left. They also have very different clinical courses in terms of when they present and outcomes. And we know epidemiologically they have very different risk factor profiles. And something we now know, due to all the molecular work that's been done, is that ovarian cancers have different cells of origin. So when we say ovarian cancer, about the only thing they share is they typically appear on the ovary, even if that's not where they started. And so we're going to delve into one of these subtypes called clear cell carcinoma. This only makes up about 5 to 10% of ovarian cancer. So it's a rare cancer among rare cancers. And here you see the tissue of origin is traced back molecularly to the endometrium, actually, likely through endometriotic implants that find their way to the ovary, and that's where the cancer takes off. This subtype has extremely poor survival because it's typically resistant to the standard platinum-based chemotherapy. But very interesting, these tumors have very well-established somatic mutations, of which P53, the guardian of the genome, is not one. And that's the most common mutation in ovarian cancer. So it's very different. And because of its rarity, there have not been very large multi-omic studies. So we did undertake one that combined epigenetic and transcriptomics, a multi-omic study to better understand this cancer. And as you can see from the graph on the left, we identified 2 very distinct clusters that were defined by their DNA methylation patterns. And then you see on the right, poor survival and a much worse clinical characterization for what we call cluster 1, or the blue cluster. When we did transcriptomics using RNA-seq, we found that this poorer cluster actually was more high-grade serous-like, and it did have the P53 mutations, whereas the cluster 2, the cluster that did better, had the standard mutations. So by combining multi-omic data, we identified a subset of clear cell cancers that may be more appropriate to be treated by methods now that are addressing high-grade serous. Now, to do this study, it does appear that maybe lab-wise it was simple, but it was not. But we needed to get 10 sites together to get enough samples just to do this study, to delve into this cancer. And that resulted in 271 cases. We had 4 different team leads. Ellen and Kelly were our lab people. Julie was our bioinformatician, and our group was our data coordinating center. And all of us are part of the Ovarian Cancer Association Consortium. And we're also a part of the Ovarian Tumor Tissue Analysis Consortium. These are large international consortia which allow us to come and bring our resources together so we could do these types of studies. We have over 70 studies now in OCAC throughout the world. So our first challenge is that we have a significant disease heterogeneity. Even within a single cancer, there are subtypes, and even with the subtypes, there are multiple subtypes that have different biology, prognoses, and treatment response. But I'm going to tell you there's another problem, and that's in the fact that we have significant heterogeneity in our data, both in the type and the size and the granularity that we examine together, that I think we need to understand in order for us to make any progress in treatment response and outcomes. And these data range from the population level, where you live and how where you live impacts your results, to your individual level, what's in your medical record or your questionnaire responses, to imaging data like Emma showed that goes into the body, to multi-omic data, which now goes all the way down to the cellular and subcellular level within an individual. So the next question we come to is, how do we exploit these types of data to answer questions about cancer outcomes and outcome disparities? So going back to ovarian cancer, I mentioned that we had significant survival disparities between Black and white women in terms of survival. These are actual data from women treated at the University of Alabama Medical Center. We know that factors such as access to care and receipt of guideline concordant care partially explain outcome disparities. But what about women at a single medical center, a comprehensive cancer center, that receive the same level of care? As you can see on the graph, we still see this same disparity. So we took a step back and we began looking at, okay, how does where you live contribute to this? We looked at residential social vulnerability, which was defined by the CDC Social Vulnerability Index that used 4 social determinants of health that captured several census-backed trace factors. And what it does is it summarizes that census tracks vulnerability or resilience to a disaster, but it has emerged as ways to identify areas of poor health outcomes. In our Pittsburgh cohort, which is mostly white, group of women, we saw that women living in high social vulnerability areas had worse survival. And here we see the same impact of women in our Alabama cohort, which has a little bit greater racial diversity. So then when we stratified our UAB cohort by race, we see that Black women, whether in low or high social vulnerability areas, relative to white women, will still fare significantly worse. And in fact, what we saw is that Black women living in high social vulnerability areas have a 28% greater risk of a poor outcome than we would expect. So this tells us that where a Black woman lives has a greater negative impact on her health than it does for white women. When we did our mediation analysis, we saw that where one lives partially explains these outcome disparities. But I want to remind you that all of these women were seen and treated at a single comprehensive cancer center. So they received the same level of care. So we know there's something more going on. And for that, we started looking at some biological signals, and we looked at something called allostatic load to see if we could quantify how one's lived experience impacts her cancer trajectory. Allostatic load is a quantitative way to measure the impact of cumulative stress by measuring dysregulation across physiologic systems, and we use standard tests that are run as part of clinical workup. So what is allostatic load or allostasis? When you undergo stress, you have a physiologic response. If it's acute, you will get back into allostasis or equilibrium, you'll adapt and you'll become more resilient. But this chronic stress with this chronic physiological activation leads you not to be able to get back to this equilibrium, and that's what causes this dysregulation. And what we showed in our Pittsburgh cohort is that regardless of how we put those markers together, women who have high allostatic load have about a 60% increased risk of death. We then linked this information back to what we were seeing in the tumors. And we looked at the tumor immune microenvironment, both using immunohistochemistry and bulk transcriptomics. And we see that women who have high allostatic load, their tumors are associated with a suppressed tumor immune microenvironment. They have fewer CD8 positive infiltrating cells and CD20 B cells. And they also have a significant overexpression of 7 of the cancer hallmark pathways. So in other words, this stress is actually manifesting as a poor immune response in the cancer and can be contributing to what we're seeing as poor outcomes. We know from the literature that Black women have higher allostatic load. And so now we're working on trying to put all this together. We see that residential context is associated with poor outcome, and this has a greater negative impact on Black women. We see allostatic load is associated with poor outcome, and it's associated with a suppressed tumor immune microenvironment. And Black women have greater allostatic load. But where do we go from here? And this is what our group is now working on, the idea that our life experiences become biologically embedded into our body. And this is a figure from the early life adverse event literature, but I think it holds equally for any of our experiences and how those experiences, together with our individual genetic and other factors, set the stage for cancer or the inability to overcome a cancer. So briefly, our experiences do impact our nervous system, that impacts our endocrine system, and that spills over into our immune system and our metabolic system, and it's a cycle. And in other words, our lived experiences become embedded in our physiology, and that's what's contributing to differences in risks and outcome. And so I posit, and our group is focusing now on taking a society to cell approach to overcoming cancer and outcomes and outcomes disparities. And what we are trying to advocate for is to stop these siloed approaches. So all the data I previously showed you are these siloed approaches where we look at one individual thing and then we try to put it all together. And what we are now advocating for is to look at this more comprehensive approach, integrated. So our challenges are not only the disease heterogeneity, but this multi-level data and how do we put it all together? And that's the next question. Now, when we first started out, we didn't have that technology, but I think we now do. And so one thing our group is actually looking at is how do we adapt the large language model framework to integrating all these different types of data so that we could understand an entire composite picture better than we can by looking at the different individual parts using standard statistical or informatics techniques. And I would be very excited to talk about different approaches that people may have to thinking about how to do this. But I want to point out that even if we are successful technologically, we do have another challenge, which is in data sharing. We know that data are very heterogeneous across systems. Even if we're asking for the same types of data, they're collected differently, they're defined differently. Once you ask for medical record data, in comes privacy concerns and HIPAA and all sorts of institutional policies. There are definitely infrastructure barriers, and those are particularly true in more community-based hospitals when we try to collaborate across outside of our cancer center into community-based hospitals. And that's a problem because most women from marginalized communities will seek their care at their local community-based hospitals. And that's one of the challenges we have in getting representation of all groups in our populations. And that's what impacts health equity. There are emerging solutions, and I know there are many people in this room who probably can talk to them better than I can. Technologically, we focus more on practice, although we are trying to also break out into technology. So the complexity challenge I talked about is threefold with disease heterogeneity, the data heterogeneity, and how do you share these data? Moving forward, I think we've talked about how do we integrate this biosocial framework into our data and how do we build sustainable, equitable data systems? And then how do we expand our precision medicine approaches to include these structural, environmental, and social determinants of health? And then something we never talk about when we talk about science is how do we train the next generation of scientists, which I guess as I'm coming towards the end of my career is something I focus more on. How do we train the next generation of scientists not to be in these silos, but to actually think convergently, something that's critical to the NSF? So I want to thank all of you for your time, and I in particular want to thank all the women who have participated in the various studies we've done throughout the years.
Thank you so much, Emma and Francesmary, for your wonderful presentations. It was interesting to not only see some of the technical tools that you're developing, but also how you're using them to really address a lot of health disparities, in particular with cancer and for cancer or cancers that are more commonly associated with women. So I'm Freya. I'll be facilitating the Q&A portion of this session. As previously mentioned, we'll be using Slido for the question and answer. When you ask your questions, feel free to have it be a broad question or have it be specifically for either Francesmary or Emma. And please also upvote questions that you want to have answered, and I'll try to do my best to ask the questions that have the most upvotes. So the first one is for Emma. This is from Anne. Could you provide more details on how your hypothesis generation works, including where human input is still involved and where it is no longer necessary?
Yeah, this is such a great question. Thank you. Right. So basically we have these models, foundation models, right? These very large neural networks that are very good at predicting things from rich data, whether it be text, whether it be medical data or whatever. So basically what these models are learning is a very, very complicated function from the original data to some kind of prediction, like, your cancer prognosis or whether you're going to have a heart attack, something like this. We don't understand how these models do these predictions. We know that in many cases they are more accurate than humans. So the mystery is, why are they more accurate? But the problem is it's hard to know how these models do what they do, because if you look at the inner components of the models, the neurons that make up the neural net, these neurons do not correspond to human interpretable features. So what we have been using is methods that sort of take these original uninterpretable representations in which sort of a single component, a single dimension might represent many different things. It wouldn't just, represent some nice, cancer histological feature. It might represent like 16 different features simultaneously in some complicated way. So taking this thing which is hard to interpret and converting it into a representation in which each dimension of that representation hopefully corresponds to something which is a distinct concept. Okay, so so this is like a very powerful technique in general to sort of illustrate it in the context of text. Now you have sort of a vector representation of your text where each dimension of that vector like corresponds to, poodles or, cirrus clouds or something like this. And then now that you have this vector with human interpretable dimensions, you can then take that vector and correlate it against things that you might care about. Like, does this headline get more clicks? Does this patient develop cancer? Stuff like this. Now, to the necessity of human in the loop, this question is close to my heart because I'm not really a fan of obviating humans. I was actually just talking to my wife about this morning. She's also a computer science professor, and I think both of us are a bit leery, reasonably, of this concept. And I think the good news is that at present, and I hope in future, humans continue to be an integral part of this process. So like in the context of ECGs, like we've been applying our method to ECGs, and like your method spits out a bunch of features, these ECG patterns, and then the question is sort of like, okay, well, are those interesting? What do they mean? Have cardiologists seen them before? What should we drill down on? And so I do think having human experts to sort of guide exploration and sort of identify which of these patterns are most interesting, most novel, most useful, is at present quite essential. We've certainly found that sort of AI agents are somewhat useful in terms of like roughly ranking things in terms of what's most likely to be useful. But at present, I think it's pretty essential to have a human in there to be like, okay, well, here are the stories or sort of the things with the most practical applications out of the like many thousands of things you might pursue.
I kind of have a quick follow-up question on that. So people talk a lot about the potential for ML to introduce bias. So how do we, when we're creating these types of tools, sort of benchmark or evaluate this kind of work to make sure we're not introducing bias?
Yeah, I think that's a great question. To the extent that the original models themselves encode various biases. So, for example, I don't know, maybe you trained your foundation model to predict cancer prognosis, but you trained it only on white women or something like this. Then, to the extent that the model is encoding biased or incomplete information, our interpretations of that knowledge are going to suffer from the same biases or incompletenesses, right? And that's clearly an issue. And this is something I've certainly thought a lot in my past work because, we think about inequality and therefore about algorithmic bias. And there are various, solutions to that, of which an important and not easy to implement one is just like train your model in the first place on data sets that are representative of the populations you'd like to learn about or deploy them on. Easier said than done in many cases. One thing I would say about these interpretability methods that let you see how the models are doing what they're doing, is that they can be quite useful in identifying these biases, right? Because they can tell you stuff like, hey, you think your model is like making great predictions from chest x-rays of like whether a patient has a disease. Actually, it's just like detecting some like very trivial confound in the data set. Like, the patient has like a pacemaker and it's like, great, they have some heart condition. Clearly, we already knew that. And so I do think these interpretability techniques are useful, not necessarily for fixing biases, but at least for identifying them when the model is sort of making predictions on the basis of stuff that is not really true signal, is not what you want.
Thank you so much. So moving on to our next question from Linda Ambroso. How do clinicians get and use the results of data analysis to improve patient outcomes? Must they read journal literature, subscribe to updates in their fields, or get notifications from their employer? Continuing education. I worry the average clinician may not have time or will to use the analysis. As someone who's pursuing both the MD and the PhD, I think about this a lot. So would be very interested in hearing about your perspectives.
Yeah, I think it's a very big problem. I think information overload is a big problem. And I think some of the things that our healthcare system our UPMC system is working on is incorporating some of this already into the pathway that clinicians use when documenting things in the electronic medical record. So, for example, they can have a guide that might prompt the physician to think about certain things if they record certain information on a woman. So I think that's one of the ways this information gets in. But all the ways you list are the ways that clinicians typically keep up to date. And it's challenging. And when we do discuss things with our community-based physicians, they will tell you that they have to see so many patients in a day. They don't have time to really think about how to deviate or look at a patient in a way that they might treat differently than the recommendation, because they just don't have the time to learn all of that information. But then even in a consult, spend the time to think above and beyond that. So I do think we can do a lot of work with AI-based agents to help physicians in that way.
Thank you so much. The next question is actually from Gabby for Emma. How are your analyses on fair decision making by humans used to improve these behaviors? For example, in your work on disparities in policy, policing or medicine, can your data identify what changes would be effective to reduce these inequities?
Yeah, this is a great question. And I think the answer is sometimes. Sometimes. So like in the case of policing, we developed these statistical methods to try and identify racial disparities in traffic stops and sort of in police behavior post-traffic stop. So concretely, for example, are officers more likely to be searching minority drivers post a traffic stop? And we found evidence of these disparities, and actually probably more impactfully, journalists applying our method found evidence of disparities when they analyzed data and wrote about it. And the reason I say more impactfully is like when journalists write things, more people read it than when I write things. So they found this and they wrote a story about it. And the methods cannot like pinpoint like exactly why these disparities emerge. Does the officer have a specific racial animus or something like that, or link it to like specific experiences the officer had or something like this. And so I think they're deficient in that way, but nonetheless, I think they can still suggest concrete policy changes that you might make. So, for example, after the journalist published the story, the Los Angeles Police Department announced that they were going to dramatically cut down on random vehicle stops because there was sort of clear evidence of racial bias post-stop. So, like at the very minimum, like if some behavior is resulting in racial biases, you can try and curtail that sort of behavior, and that has happened in other contexts as well. So, like in New York City, this was not our work, but there was this large-scale stop and frisk policy pursued by Michael Bloomberg and others, and like whatever the sort of mayors might have said about that policy, it was very, very, very obviously racially discriminatory, and it was sort of subsequently curtailed by a federal judge, and that decision was made in part on the basis of expert witness testimony that sort of concretely demonstrated that there were sort of Fourth and 14th Amendment violations. So I do think statistics can inform policy change here, even if they can't identify exactly all the reasons that people are doing what they're doing.
Thank you so much. I actually kind of have a follow-up question on that. So, as a researcher, do you know of any avenues that we could pursue in order to actually have these types of policy changes? Or do you find that it's more often that you're just asked as an expert as policymakers are trying to push policy forward?
Yeah, it's a good question. I mean, I think one thing is sort of trying to focus your research in the first place on questions that might be policy relevant, right? So policing, I think, is one area where certainly this stuff has been policy relevant, and that's one reason that I continue to work on it, because it seems to be an area where like people care and things happen in the real world. Um, I think this stuff on the use of race in medicine, and one reason I got interested in that was because it was clear that hospitals were changing their behavior. And it wasn't clear to me they were always doing so in a way that I agreed with. And so that was sort of why I started writing about and thinking about that issue. To be perfectly transparent, it's not at all clear to me that anything we've written has resulted in concrete policy change. I think that's another thing which is sort of hard to tell here, right? Is it can be difficult to like be like, oh yes, we did X, and then as a result, this policy changed, or was it really sort of that you like subtly shaped the zeitgeist in some long-term way? But I do think sort of focusing on questions where it's like, okay, you might be able to move the needle here. There might actually be a lever to change people's behavior. Here, I think the concrete theory of change would be like, if you critique the way that algorithmic changes are being made, perhaps hospital systems will change their behavior and stop doing this, right? And so I think there is sort of a concrete theory of change there. Maybe one heuristic would be sort of like, okay, well, like what behavior might actually change on the basis of the analysis I'm doing, right?
I wanted to add something to that, and which is something we know and also relates to the previous question about how do clinicians get this information. We know there's about a 17-year gap, which is actually astonishing, between the time we know something works medically till it makes it into common practice. And I think that's another interesting area where people could start thinking about how do we get that information into clinical practice faster. But I think the same is true for policy making. Think about breastfeeding. We knew for many years, many years ago, about the health benefits of breastfeeding, but look how long it took for breastfeeding to be pumps to be covered by insurance, for workplaces to have specially dedicated lactation rooms. So I think that's another thing we can think about, is how do we get these moving faster?
Oh, thank you both so much for your insight. The next question is from Melanie Smith. So for Emma, for extracting data for electronic medical records, how do you/can you account for biases regarding how women's subjective symptoms, such as pain, are actually documented?
Yeah, it's a great question. Right. And yeah, I mean, I think this is a tricky thing, right? Like you want to study like these patient reported outcomes like pain, and clearly they're important. But there may be differences, in how people express pain across groups, how comfortable they are expressing pain, how doctors document that pain. And I think that was a and then when you contrast it with like objective clinical measures like your creatinine or something like this, it's like, okay, that's like a blood test, we did the thing. And so I think it is a tricky thing, and it's certainly something we thought about in our pain study. I mean, in the pain study, basically what we're showing is like, well, there is some objective biological thing that, something in the knee X-ray that is predicting, the patient's self-reported pain. And so there is some objective biological correlate of that. It does not just seem to be in their head. And we were able to sort of rule out various confounding factors. But I think it is a tricky thing. I guess my more general answer to this question is I think it can be useful to sort of combine these more objectively measured and subjectively measured or reported things, because I think they're complementary to each other, and they suffer from different deficiencies.
Yeah, I think it brings up the good point of a lot of the times our research is only good as the data sets that we have access to, which actually brings me up to a question that I personally had for Francesmary, which was you found a lot of interesting disparities in your work. And I think a lot of that really speaks to like the diverse cohorts that you have and the diverse data sets that you've generated. As someone who's interested in sort of clinical cancer research, What is your advice on how to develop these sorts of diverse cohorts? And I know you've worked with a lot of different consortia and how that plays into that as well.
Yeah, I mean, that's pretty much what you have to do. You have to find these different locations, which is why I collaborate with people in Alabama, because they have a much larger self-identified Black population than obviously we have here in Pittsburgh. But that is really the way things are being done now, is through these consortia. We have them in breast cancer, we also have them in endometrial cancer, and that's one of the reasons why, so that we can, and that's why we want them to be international too, because there are differences not just based genetically, but there are just different social differences that are different across countries and across continents and how things are approached. So yeah, I think consortia are the way. It's the only way we're going to go, because no one medical system is going to have the diversity. I mean, there are more diverse medical systems, obviously, but you always want to look at something in one population and you want to see, does it hold in different populations and different approaches? Because if it doesn't, then you certainly don't want to make clinical decisions on something that is not consistently seen.
Yeah, I mean, we see a lot of these consortia across different fields. For example, within rare diseases, we have the Undiagnosed Diseases Network. But I think there's a lot of spaces where consortia still don't exist and that there's a lot of space for building them. Do you have any advice or feedback on how to sort of integrate this consortia development and how to actually make it be an effective tool for spaces where it doesn't already exist?
Yeah, well, we all came together, believe it or not, because we knew for the ovarian cancer one, we were all funded to do our one little study, and we realized that technology was advancing so fast that none of us were ever going to have the power in an individual study. So really, it had to come from the investigators. We did get some initial support from the NIH, and we got some initial support from some foundations to do this, but now it just runs on our volunteering our time to contribute to keep it going. And that's a challenge these days with the tight funding situation, because now our time is even more constrained, right? Before we had a little bit more flush and you can have extra time to do these things. So I think it takes a small core group of committed people, and I think it takes coming together and really aligning on a vision, and then bringing that vision to fruition. And one of the things we're now pushing for in our consortia, as all of us who started it are getting ready to retire in the next decade or less, is how do you now bring in the next generation of researchers and transition everything? So I think thinking about the infrastructure, thinking about how the data are hosted, how the data are shared, all of that has to be done up front to be successful. And definitely just a collaborative mindset, and everyone keeping the main goal in mind, which for us is to help women.
No, I really love that sentiment. As someone who's very enthusiastic about team science, it always makes me excited to see such broad collaborations. So the next question is sort of a general question to both of you. So this is from Mike Timlin. Are you able to find 98% confidence interval correlations that lead to causations, or are you often limited to some correlation less than 98%, which may indicate something that's more multi-factor causation? They're just curious, as there seems to always be genetic components to cancer, but it might also be nature or nurture or both, or how do you tease out between these two?
Yeah, so that's a challenge. And again, I posit that it's actually multifactorial. And depending on who you ask, you'll hear that 40 to 60% of cancers are preventable because it's lifestyle choices, diet, exercise, obesity, smoking. But there are definitely genetic components beyond the known genetic, the very virulent genetic, like BRCA mutations that are very highly associated with cancer. There are genetic components, but again, I think it takes these very large data sets and these very clever models, that these standard statistical models that we use, again, need to be replicated across all different study designs, all different populations, before we have confidence that what we're actually seeing is true. And correlation is not causation, right?
Yeah, I agree with that. And right. I mean, to the point, I mean, to this point about 98% confidence intervals or whatever, I mean, you can have very large data sets with very high degrees of statistical significance. And the question of causality can often kind of be orthogonal to that, right? It relies on sort of assumptions that are unverifiable, and often may not be true in all data sets. One thing I would add to that, I agree with everything that was said. One thing I would add to that is like, I think a lot of the questions we study are sort of descriptively or predictively interesting, even independent of causality. In other words, if I can like look at your ECG or at your histopathology slide and sort of better predict your prognosis, that may be interesting to you, independent of whether I've identified causal things or it's merely predictive, right? Because like I'm telling you like whether you're going to be alive in 10 years or something like this, or giving you some sense of that, and that's just useful. And I think that's, you know, it's also just like sometimes things are just descriptively interesting, independent of causality. So if I like document like large exodus of people in response to some wildfire, well, actually, I guess I'm sort of implicitly using causal language there. So perhaps I am assuming, but you know, I or like documenting migration trends independent of the cause, that can often just be interesting or useful to know.
And I want to add to that that looking at statistical significance doesn't mean it's clinically significant, right? If we have a really large data set, we are going to find statistically significant things, but does it mean anything is the real question.
Yeah, again, as someone who's interested in going into clinical medicine as well as research, I think this is something that we talk about all the time in terms from the medical perspective of, is this research actually going to have an impact in the clinic, or is this just an interesting finding that we could build upon? So the next question is for Francesmary from Gabby. Given the differences in outcomes with high allosteric load, how are you or the Bigger Ovarian Cancer Consortia thinking about changing how to monitor or treat cancer patients with high allosteric load? Otherwise, what questions still need to be addressed about the mechanisms?
Yeah, so the allostatic load work we haven't brought to the consortium yet because that requires medical record extraction, and our consortium are studies that are somewhat frozen in time. And so to go back to medical records is especially challenging. Like our HOPE study was done in the early 2000s when, believe it or not, we still had paper-based medical records. So getting that information is a bit challenging. And so, well, again, this is the idea that if we can identify the women who are going to be at high risk for treatment failure, what are things that we can do? So allostatic load is indicative of stress. Can we look at already FDA approved neuromodulators that might be added in conjunction with chemotherapy that might make the chemotherapy more effective? And so all of those are the types of questions that we're asking in our interdisciplinary group here by, you know, again, finding these associations, then going back to the lab, looking at model-based systems, mouse models, organoids, new three-dimensional models, seeing what we see, and then saying, can we then take it forward to the clinic and see, can we identify agents that might help in dampening if we are seeing that women who have high allostatic load have this lack of an immune response. And we're also looking at tumor neuronal invasion, so infiltrating of nerves. So if we're seeing high infiltration of nerves, can we look at those drugs that might blunt those responses to allow the immune system to kick in better?
Thank you so much. Gabby, if you have any follow-up questions, feel free to pipe in. But I think that leads us to our last question, potentially during our formal session, which was actually posted before the session. So I kind of wanted to extend it into a broader question as well. But it's came across two women I'm close to with SCAD in the last 3 months. Not much research done, I hear. I'm not medically trained, but happening across two coasts in close time proximity just makes me wonder, is it possible to use data available to arrive at causes for prevention? And my question is just sort of how can we do this broader across all different types of diseases and conditions and indications?
Yeah, so medical record data, like Emma talked about the analysis she's doing that you can do in a medical system, especially a medical system that is kind of closed, meaning that people have been in it for most of their life, where we have historical data. So that's a little bit challenging in our country because every place you go, there's a different medical system, even within your own city. But, European countries that have socialized medicine that have all historical documents are exactly the population-based registries that can look at this and identify what are the risk factors, what would predict these outcomes, and take it from there. Emma could probably address it a lot more detailed.
No, I mean, I totally agree with that and would just second the jealousy around European data and not just Europe, but sort of other countries that actually basically have their act together and have centralized record keeping systems where you can sort of a single ID allows you to track someone over their entire life. And certainly a goldmine for sort of studying the clinical aspects of things, but also for the sort of social determinants of health aspects that we've been discussing. Amazing goldmine because you can do stuff like there are studies out of Sweden studying stuff like, if you have a child that has, if you give birth to a baby that has some kind of negative health outcome, what's the impact on, like, for example, the mother's future earnings or stuff like this. And you can only do this if you can link detailed fetal records to subsequent labor market outcomes, which it blows my mind. So basically, we should all move to Sweden is my takeaway from this. And indeed, you will see grad students, like American grad students, who spend substantial fractions of their PhD just in random Scandinavian countries to sort of chase this sort of data because you just can't do it here in the U.S. I do think in the U.S. things are getting better, and we do have access to very rich data in various ways, but we don't have that kind of unification across multiple data sources, and it's a very powerful thing.
As someone who is Swedish, I can also second this idea of everyone moving to Sweden. We're almost at time, but I have a follow-up question for Emma that I'll ask during our sort of bonus 10 minutes after the session, where our moderator or our presenters will stay and answer any additional questions. But for those of you who wanted to leave at 10:30 or have something to go to, we wanted to thank you so much for coming. We will be posting a recording of the session and then also sending out a survey. So please look out for that and please fill out the survey and give us feedback on things we can improve on and things that you liked about the session. And we appreciate you all coming, and thank you so much to Francesmary and Emma and Gabby for facilitating and presenting today. It's really been a wonderful discussion and conversation. But now during our bonus time, I kind of wanted to ask a follow-up question to that, Emma, I think it's very powerful to be able to use a lot of these sort of nationalized data sets that we have in other countries. How do we go about sort of using the information that we can glean from those data sets and actually apply them here in the US? Because we know there's a lot of differences, obviously, between different countries, both socially, economically, biologically, especially in the US, where we have such a heterogeneous population. How can we actually effectively use the data that we glean from that to sort of translate into the US?
Yeah, I think this is a great question, and I think we should be transparent and honest about the extent to which things do and do not generalize. To give one example of this, so maybe a decade or something ago, Britain, to their great credit, came up with this really nice resource, right? The UK Biobank, which with lots of good information on sort of both the social side and the health side. Thousands of papers probably written on it. But if you want to study, racial disparities, it's not a good data set. The data set is something like 95% white or something like that. I may be garbling the number slightly, but and then also, do the sort of racial disparities you could observe in any case generalized from the UK to the United States. I think that's very unclear. And so I think it's a question of sort of identifying questions that maybe plausibly do generalize. So perhaps, maybe you have socioeconomic inequality, and that might be more transferable across countries. At the same time, it's not totally clear, right? Because, if you have sort of universal health insurance, right, which in the United States, the consequences of being very poor in other countries may be quite different than they are here. So I do think it's a problem. I guess the other thing is if you study something in Sweden, it's still relevant to lots of people. They just may not be Americans, and so I think that's still a valuable thing to do.
What do you think would be steps forward that the US could take despite not having a lot of these like nationalized systems. So still try to gather this information using the tools that we currently have available.
I can answer that, but Francesmary, did you have thoughts?
Yeah, well, I was going to add to your comment about the previous answer to the previous question that again, we have to test things across different populations for all the reasons Emma mentioned, because there are these, this is why we're looking at this more comprehensive approach, because there are just going to be factors that are going to change outcomes that are not going to be the same across countries, across populations, across even healthcare systems. You know, people don't realize, but some European countries only do screening mammograms every 3 years. That's all a woman is entitled to, whereas we are entitled to do one every year. And how does that impact outcome? Because cancers might be detected later. So those are all the reasons why you have to repeat these studies in all sorts of populations through different approaches, different methods, because it's only when you have agreement across approaches and populations do you actually have a true signal. And that doesn't mean a signal that you pick up in one country isn't valid, as Emma said, in that country or other populations. It just might not be universally applicable.
Yeah.
I lost track of what that follow-up question, of what we can do here in the US. Yeah, that's a challenge, right? Now, again, with electronic medical records and the attempt to standardize them across medical systems, I think is going to hopefully go a long way. A lot of medical systems, we have Epic, and a lot of other places have Epic as well. And so it makes sharing across systems a lot easier now. They're actually building in research components so that people across medical systems can collaborate.
Yeah. Yeah, I agree with that. Just to say a little more on the failure to generalize, this, by the way, I think is one of the concerns about the use of race in medical algorithms is like race just means different things in many ways in different countries. It's recorded differently. The categories are different. Certainly the racial disparities are different. And so, you develop an algorithm in one country, will it generalize to other countries? And in some cases, no. And these things are used broadly. In terms of improving the situation in the United States, I mean, I do think, one thing that has been helpful is, there are these collections of these biobanks that we've been discussing so for example, like I think the All of Us effort has been useful in that regard, that the NIH has spearheaded and supported. And that's rich social determinants of health data combined with genetic data and other EHR data, and I think that's an exciting thing. I do think some researchers, have had luck sort of linking across multiple data sources or multiple EHR systems, but it's just harder to do here. I don't mean to say it's impossible to do here. I think there's a lot of great research being done in America on American populations as well. But yeah, I think in terms of larger scale policy change in America, I'm not tremendously optimistic about larger scale policy change in America at the moment, I guess.
Yeah, I think it really just highlights Francesmary point earlier of, we have to use the tools that are available and try to be adaptable with multiple different types of data that we're receiving. So there's one question in the chat from John Jay, who was having problems with the Slido app previously, but what is the #1 preventable female specific disease in the US? And he appreciates your time and being able to be here.
Yeah, so I don't know what is the #1 preventable. I do know cardiovascular disease is the #1 killer of women. So I think that, a heart healthy and a healthy lifestyle goes a long way in preventing a lot of things, a lot of different diseases.
Emma, anything in
I
particular?
don't know. I don't know that I can totally answer that question. I think there's a lot of room for opportunity or leverage around improving the treatment of women's health conditions. I think we have a lot of evidence that decision making is heterogeneous and suboptimal. So, for example, like, we have large racial disparities in maternal and fetal health outcomes. that does not feel inevitable or preordained, right? And I think that's one general thing. I think also in general, many of these questions have been under-researched relative to the fact that they impact half the population. So that's not exactly an answer to the question, but definitely for example, I do think questions around pregnancy and sort of improving fetal outcomes are definitely an area where we can improve a lot and have not made use of all the data we have access to and could narrow some of the disparities that exist.
But I do hold that there are so many commonalities that just improving certain things, improving communication, improving infrastructure, improving lifestyle choices for people, identifying these communities where people will have poor outcome and helping create the infrastructure to address is not just going to address cancer or heart disease or maternal fetal outcomes. It's going to address all of these. And I think that's the approach we have to take as a society.
I 100% agree. This will probably be our last question. It's from Linda Ambroso. How do the findings we are now seeing get converted into policy and policy execution in the federal legislative and executive branches and also the state? Is there a lobbying organization or research group that interfaces with government and clinical stakeholders?
I think that a lot of that goes down to the different medical associations, the different subspecialty associations that work with their constituents to get information out and then to actually lobby for changes in policy.
Yeah, I mean, to speak, I mean, when we have a finding we think is policy relevant, we just try and make as much noise about it as we can. So we'll try and write about it in newspapers, for example. Sometimes we may try and sort of reach out to folks who might be more specifically relevant, or they reach out to us. So like some of our work on policing, we hear from public defenders, stuff like this, and then we talk to them about that. Or work on flood detection, we talk to people placing flood sensors throughout New York City. So I think just sort of both this sort of broad, like, hello, we're here, and also sort of more targeted outreach. But I do think it's really hard. And also I think the impacts of it are difficult to measure. And also, like, even when there are obviously good policy changes that should be made, it can be challenging to make them. Just to give one example of this, like I think, and a bunch of other AI researchers I've talked to, one great policy change we could make is if we, these companies like OpenAI, Anthropic, et cetera, were required to have external researchers have access to their data and be able to publish freely on the societal impacts of their models so that we could better study stuff like, I don't know, people going into like psychosis, death spirals as a consequence of conversations with chatbots. Currently, that's not true. It would probably be good if it were true. Most AI researchers think that, but making that happen, I don't know, very, very difficult thing to do. And so, yeah.
Yeah, no, it's always very inspiring to see researchers that are thinking of all the different hats that you can wear as a scientist, sort of both as a, researcher yourself and then also as someone who's trying to affect policy. Um, with that, that will be our last question for this session. Thank you all so much for coming. Thank you again so much, Francesmary and Emma. It has been such a pleasure chatting with you and hearing more about your work. And thank you so much to the Hertz staff as well for supporting this wonderful event. Without them, this would never be possible. And thank you to Gabby for helping facilitate the session as well.